good afternoon, and welcome to the Bidders Conference for the Chicago Department of Public Health's request for proposals for substance use outpatient services for persons with HIV. My name is Patrick Stonehouse. I use he, him, his, but anything with respect is perfectly fine by me. And we're just going to go through, we're going to go through this whole thing. Let people in as they come through. So this is one of our final requests for proposal for the season. I think there may be one or two more, but there may not be. So we've done a whole bunch of these, and thank you very much for participating in them and for submitting proposals. This is I think of the bidders conference as like the midpoint of the contract procurement process after all the writing is done and reviewing, and this is the point at which it's being released to the general public, and then goes the process of reviewing all the proposals, I should say, and issuing the awards. So let me go ahead and share my screen. All right, can you see my screen?
Yes.
Thank you. All right. So, again, this is the request for proposals for substance use outpatient services. During this presentation, we'll do a brief overview of the portfolio of services supported by the Syndemic Infectious Disease Bureau. We'll talk a little bit about substance use outpatient services and then align with Healthy Chicago 2025, guiding principles of the Chicago Department of Public Health, and a bit more. So, for those of you who are not aware, the portfolio that we put out as the Chicago Department of Public Health's Endemic Infectious Disease Bureau is intended to be an interconnected system of services, wherein even if there is, as there is with substance use outpatient, like this is the only service category funded by this particular request for proposals, there is still the intention for the services provided through substance use outpatient to be coordinated and connected to all of the other services that are made available through other RFPs put out by the Syndemic Infectious Disease Bureau. So it is not intended to be an independent, standalone thing. It is meant to be a single contract or a contract for a single service category that is participating in the network of other systems and structures and services to try and bring about the greatest level of health and well-being for people with HIV in the jurisdiction. The portfolio across all integrates funding from a number of different funding sources, Centers for Disease Control, High Impact HIV Prevention and Surveillance, Ryan White Part A from HRSA for HIV for care and support services for persons with HIV. HRSA's Ending the HIV Epidemic, Housing Opportunities for Persons with HIV, City of Chicago Corporate, and a couple of others. And wherever possible, we try to blend or braid these funding sources together to allow individuals to receive the services regardless of their HIV status. So to make the service available to individuals, both those who have HIV and to individuals who have a demonstrated vulnerability to HIV. We're not always able to do that, however, as is the case with this particular request for proposals, which is solely for people with HIV. So this is a substance use outpatient that is funded through Ryan White Part A funding, and therefore the only individuals who are eligible for it are individuals with HIV in the eligible metropolitan area. Similarly, whenever possible, we try to use a syndemic approach, so meaning that we're looking at the impacts or experiences that individuals, communities, and populations have as a whole, as opposed to as an individual area of public health concern. So we want to talk to folks about, yes, HIV, but also viral hepatitis, tuberculosis, Mpox, sexually transmitted infections, substance use, experiences of community violence, experiences of community strengths as well. So looking at the strengths-based perspective, what are all of the varying positive and negative influences that folks and communities are experiencing. And of course, we want everything we do to align with priorities set forth in Getting to Zero Illinois 2.0, the National HIV/AIDS Strategy, the National Ending the HIV Epidemic Initiative, and other national plans. So generally speaking, We can like build HIV services or the portfolio into four buckets. So we have our healthcare, which is the clinical service delivery, and we have health equity, which is more of like population-specific efforts that are focusing on the experiences of specific populations that are most impacted by HIV and systemic infectious disease. It also applies to the manner in which we analyze and evaluate the performance of programming that is not population specific through which we're looking at the programmatic data from, say, like an outpatient ambulatory health services, and looking at how are you as an organization accomplishing your outcome goals across all populations, and then focusing in on how are the populations most impacted by HIV experiencing your services and those desired health outcomes. Housing is exactly that. We do have our housing opportunities for persons with HIV. We also have housing opportunities for persons vulnerable to HIV, and how to, which is about resource coordination, making sure folks know about the services that exist and how they can best access them, and then having the ability to do what they need to do in order to be able to use those services to the best of the design. Roughly speaking, this is sort of the map or of the portfolio, the idea that we as a jurisdiction built the portfolio on top of. The idea being that individuals enter into a system through recruitment and screening, and then depending on the status in terms of HIV, it splits into either going up here for persons with HIV or down here for persons vulnerable to HIV. If an individual is identified as having HIV, then it's was this something that was already known, meaning that they had a previous diagnosis, or is this a new diagnosis? And while the steps that are then taken to connect an individual to care and support services may very well be the same in terms of those actual steps, the engagement and the activities involved in the engagement may very well change because of the individual having a previous experience with that system. But the end result of this idea is that an individual will be engaged in care, retained in care, and provided treatment, adhere to that treatment, and achieve viral suppression. Similarly, for individuals vulnerable to HIV, if they're identified as having a demonstrated vulnerability and are interested in being connected to pre-exposure prophylaxis, then we schedule appointments, we connect them to clinical providers, and ideally they receive all the supportive services they need so that they can achieve ongoing PrEP adherence if that's what they're looking for. And underneath that is ongoing access to support services, including behavioral health, which would then include substance use outpatient services. Surrounding all of this are a collection of other activities that address sort of the environment or general experiences of populations. We have our housing programming again, marketing and communications, which can be general population, can be specifically for clinical or non-clinical providers, and can be specific for populations or communities. If we're able to develop strong enough relationships where we can get direction from those communities so that we're using language that they are saying is the most appropriate to use when trying to communicate this information to their peers. HIV and STI and systemic infectious disease resource coordination. This is all about just you call a phone number, you reach out a website, you go into a place, and the resource coordination activities are able to try and connect you to whatever it is that you're looking for. Community development is our systemic and structural intervention. So for those populations for whom you can have all the wonderful clinical and supportive services imaginable and still not enough because there are systemic and structural barriers in place that prevent them from accessing or benefiting from those clinical and supportive services. The community development programs were designed to be population-specific structural or systemic interventions to try and address, break, or at least bend those systemic and structural barriers for the populations that are of focus within them. And then services for people who use drugs. This was a comprehensive, or attempts to be comprehensive, a significant amount of harm reduction programming focusing on individuals for whom substance use was an active part of their lifestyle and existence. During the summer of 2025, it was decided to shift services for people who use drugs from the Syndemic Infectious Disease Bureau over to the Behavioral Health Bureau so that it can be embedded with other activities that the Behavioral Health Bureau already funds that lend themselves towards, synergizing with the stuff we did for services for people who use drugs. All right, substance use outpatient services. So, the City of Chicago, acting through the Chicago Department of Public Health, seeks qualified organizations to provide substance use outpatient services that address substance use issues experienced by individuals with HIV in the Chicago eligible metropolitan area. And the EMA includes Cook County, DeKalb County, DuPage County, Grundy County, Kane County, Kendall County, Lake County, McHenry County, and Will County. Ryan White Part A dollars will exclusively support substance use outpatient care services for individuals with HIV. Currently, so we have contracts that involve substance use outpatient services as part of the for contracts with organizations that are implementing the population-centered health home model, which for those of you who don't know, was intended to be a collection of clinical and non-clinical supportive services that are available to individuals all either at the same physical location or through the same network. So, reducing as much as possible the need for individuals to jump from one place to another place in order to get all the services and supports they were looking for. That contract for population-centered health homes ends at the end of February 2026. And so beginning March 1st, 2026, substance use outpatient services will be implemented as independent contracts within that coordinated network of clinical and non-clinical services. So it has been extracted from the population-centered health home and put out forth as independent contracts. So again, it's designed to support people with HIV who are also navigating substance use challenges, which can complicate HIV treatment adherence as well as overall health. This is intended to be part of the collection, the holistic health services available to individuals through all of the different contracts that we support with Rowan White Part A. And approximately $2 million will be made available through this RFP. The initial contract will be from March 1, 2026 to 2/28, 2028. There may be up to two extensions, each not to exceed 1 year, at the discretion of the city based on the availability of funds, the need to extend services, and the respondent's performance. And just a note on the amount, that approximate amount that will be made available. So this is based on the resource allocation that was recently completed by the Chicagoland HIV Integrated Planning and Action Council, which is the federally required community HIV planning council. So SHIPAC completed their resource allocation, which is the process by which they say to the Chicago Department of Public Health, well, you are going to issue X amount of funding specific for each of these different service categories within Ryan White. And the percentage that they assigned or they allocated to substance use outpatient services, we then take that percentage and apply it to the estimated amount of funding that we will receive for that period, and it produces about $2 million being made available. So, common among all RFPs from the Community Health Services Division of the Syndemic Infectious Diseases Bureau. So, this is all stuff that's been pretty consistent across the different funding opportunities we put out. So, this is the evaluation, how we're going to score different proposals that come in. So, once your organization submits your proposals, we do an initial screening just to make sure all of the required content is present. And then we divvy out the proposals to panels of reviewers. Those panels must be an odd number of individuals, no fewer than three, at least one of whom needs to be a person who doesn't work for the Chicago Department of Public Health, and no one who can be, no one who is like sort of directly involved in the day-to-day operations of that particular RFP. So proposals come in, like give them out to these different panels. Like a panel, the same one panel will read all the same three, four, five, six proposals. Another panel will read a different collection, and then they're going to review and score each proposal based on this, what you see here. So community reach being which is a section wherein an organization talks about where they have physical locations, where they provide services, what communities and community areas and parts of the eligible metropolitan area do they have strong relationships. And that section is worth 11 points. Alignment with CDPH guiding principles is worth 9. Program design, scope of work activities and outcomes is worth 40. The staffing plan is 10. Budget justification and fiscal capacity is 10. Quality improvement, evaluation, compliance, and data management are also 10 for a total of 100 points. So after the proposals are all reviewed by a panel, Chicago Department of Public Health gets together with that panel to talk about, any significant discrepancies or differences in scoring. So if one reviewer gave a proposal a 60 and the other one gave it a 95, wanting to bring those folks together to talk about what they saw that was different, and I hopefully get to a point where there's a general agreement amongst the panel as to the end result, the aggregated scoring that goes to each proposal, as well as recommendations for which of these proposals should move forward for consideration of funding. So anytime that a proposal is, once it's done with that review by the panel, if a proposal has an aggregated score of less than 80 points, we do not consider it any further. So that is sort of where it ends. But any proposal that receives an average score of 80 or more will move on for consideration, unless, of course, the panel is like, yeah, it had good points, but we really don't think you should fund it. Um, so that is another occurrence that can happen. So once that happens, then we take it and we review all the different proposals that received 80 points or more, and we sort of lay them out on a map of the eligible metropolitan area and start thinking about, like, all right, how can we support as many of these proposals as possible to provide as much coverage as we can for the eligible metropolitan area, and thinking about geographic space, thinking about population connection, thinking about experience doing the work, thinking about capacity to provide services for a significant population. All those things go into our, like, collection of our end proposal of all the organizations we want to fund with any given RFP. So everything that we do needs to be connected with Healthy Chicago 2025, and Healthy Chicago 2025 is the city of Chicago's plan to address the life expectancy gap as experienced between Black and non-Black Chicagoans. So the idea behind this is that we know that there are a collection of experiences in the city that are leading towards this life expectancy gap, and there are, like, these are the top 4 or 5 that we want to look at and try to focus on. But even if you're not in that top 5, we still need you to be focusing your energies on this life expectancy gap as experienced. So within what we do in syndemic infectious disease, we're thinking about it in terms of how do we create an opportunity for individuals with HIV to live as long and healthy a life as possible, and also thinking in terms of the substance use component of it. So how do we create an opportunity for individuals who are experiencing substance use challenges to have a better opportunity to access and benefit from those services? Further, all applicants are in their proposals are required to talk about how what they do aligns with Healthy Chicago 2025, and how your organization works with Black populations, Hispanic Latino populations, and other communities of color that are disproportionately impacted by HIV and syndemic infectious disease and the life expectancy gap, to incorporate their guidance and direction into producing programming that will have the desired effect. All applicants are required to respond to specific prompts dealing with Chicago Department of Public Health mission and Healthy Chicago 2025, and how your organization is generally aligned with such things, how the movement toward dismantling racist systems is incorporated into the leadership and decision making of your agency, different accountability measures that are put in place. And then further thinking about how your organization is set up, structures in order to address and be responsive to experiences of trauma that have been amongst clients, but also amongst staff of your organization. And then looking at the data, how your organization will or does look at data to identify disparities, build and adjust services, and build and adjust practices. All right, and then yeah, then the next thing is just, like, we ask organizations to talk about, again, where they do the work, where they are proposing to do the work, where they currently do the work. And that's, again, it's community areas within the city of Chicago, it's counties within the eligible metropolitan area, so that we can look at all of the proposals and make sure, again, that we have appropriate level of coverage. Um, And yeah, so if anybody has any questions, this you can send questions to John Pfeiffer too. John Pfeiffer is Assistant Commissioner of the Chicago Department of Public Health for Contracts and Administration. You can send questions to me. You can submit questions through e-procurement, and you can ask questions during this bidders conference, which we're going to now. So I'm at home. I'm not at work on two screens working on this. So very, very humbly request that if you have questions, if you could take a minute to type them into the chat so that they can be preserved, so that we can, as accurately possible, hold on to those when we publish the question and answer document, which will be done shortly. So that is our presentation. Please, let's go with the questions.
I don't have any questions, Patrick.
What?
I just don't want to leave
Really?
you hanging. I know, right? Your presentation was just that thorough.
Oh, goodness. Or you've seen like 9 of them.
But
Do you
does
want to
this
come say
have,
hi to
maybe I
them?
do have a question. Does this have scopes?
Does this have scopes?
Like a certain expectation of a certain amount of interventions?
No, what we want to do is we want to see organizations propose what they feel they can do in terms of scope, the service delivery, units of service, unique individuals who receive services. You know, you as an organization, you see this is how much money is available. This is what the demonstrated need in our community is, and therefore this is what we propose we can do with this much money. And what that does is it allows, like, hopefully you are able to give an honest depiction so that we're able to think through across all of the different proposals, both like what's cost per unit of service differences that we're seeing, which is not necessarily a plus or a minus, just it's like the eligible metropolitan area is a significant space with a bunch of different kinds of environments in it. So one cost per unit of service in one part of the EMA may be appropriately different from another part of the EMA. So it doesn't necessarily say a good or bad, but just wanting to see what organizations are able to propose doing rather than we set what we want you to do and then you have to try and make it work.
Thank you.
Yep. All right, so Cameron, are all of the services in the bulleted list on page 33 of the RFP required? So yeah, those are the expectations of organizations doing substance use outpatient services through these funding sources, and this is based on uh, service standards that have been developed in the jurisdiction, as well as performance through the previous iteration of the substance use, which was integrated into the population-centered health home model. Well, Cameron, I do see that you are typing. So all awardees must provide acupuncture services. So yeah, let me clarify. Forgive me. I think it says this, but either directly or through subcontract, right? So a referral or something like that can be used, but it must be something that a person accessing through your organization there is a path through which they can be connected to these things. So to that extent. All right. Well, we have another half hour. If you come up with a question, go ahead and put it forth. I'm gonna stick around for the next half hour just in case someone shows up who has questions, but or if a question occurs to any of you. So thank you very much for being here.
Thanks, Patrick. Appreciate it.